Hello everyone, welcome to today's specialty testing webinar on which molecular test to order for colorectal cancer. This is Carrie Damon, Product Manager for Mayo Clinic Laboratories. Our presenter today is Dr. Rondell Graham, Associate Professor of Laboratory Medicine and Pathology within the Division of Anatomic Pathology at Mayo Clinic in Rochester, Minnesota. A couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn the phone over to our presenter.
Well, thank you, Carrie. It's delightful to be here, and thank you for those who are logged in over the phone. I'm really happy to share on what molecular test to order in colorectal cancer. It's a really important subject because colorectal cancer is one of the most common malignancies in the United States and worldwide. And thankfully, there are molecular tests that can assist physicians in the management of patients with colon cancer. So I have no conflicts of interest or financial disclosures relative to the presentation, and I will not be discussing any off-label usage. So I'm confident that by the end of this presentation, those who are listening will be able to describe the clinical utility of microsatellite instability testing in the context of colorectal cancer care. They'll be able to discuss the significance of KRAS, NRAS, HRAS, and BRAF mutations in colorectal cancer, and they'll be able to list alterations that predict responsiveness to currently available targeted therapies. So I wanted to start out with a presentation of a 72-year-old woman who presented with a mass in the right colon. And for those who will have access to the slides, you can see here a picture of typical colorectal carcinoma, which is adjacent to an area that has a more high-grade appearing focus. And if we examine the mismatch repair immunostains in this particular case, there was a complete loss of MLH1 across this entire tumor, and there was a partial loss or heterogeneous loss of MSH2. If you look at all four antibodies together, MSH2 and MSH6 showed a similar pattern with partial loss of both of those markers with complete loss of MLH1 and PMS2. And so this is an example of a high-grade colorectal adenocarcinoma which shows a deficient mismatch repair phenotype, and there's primary loss of MLH1 and PMS2 with secondary loss of MSH2 and MSH6. And so this is a somewhat unusual or less common pattern of mismatch repair immunohistochemistry results, but it's a nice illustrative example of how we use mismatch repair results and the way in which we interpret them. So with that backdrop, I'm going to turn now to our molecular testing in colon cancer. So the National Comprehensive Cancer Network, the NCCN, recommends universal Lynch syndrome screening. And the data supporting that are many, but one key piece of evidence is that bona fide patients with Lynch syndrome are missed if you only use criteria-driven screening. So clinical criteria and research-based criteria like Amsterdam criteria will miss 25% of patients who truly have Lynch syndrome. And morphology, of course, is useful, but it's not an adequate screen because we know by morphologic criteria alone, we will miss cases of bona fide Lynch syndrome. So now universal screening is in routine practice in many academic centers in the United States. So in terms of how to screen, most centers, and we here at Mayo Clinic are no different in this regard, we evaluate all newly diagnosed colorectal cancers. Now the mechanism or the means by which people screen vary. Some institutions will use PCR-based microsatellite instability testing. Others will use mismatch repair immunohistochemistry. Some will use the two in combination. Or some centers are beginning to use NGS or next-generation sequencing-based microsatellite instability testing. So before we proceed further down that line, I think there's some key definitions not to conflate. I think that this will allow for easy communication in practice. And those key definitions are what is microsatellite instability. And that is really the phenotypic manifestation of hypermutability. And in repetitive sequences in the genome, of which there are about 10,000 repetitive sequences within the genome, microsatellite instability refers to this hypermutability at these particular sites. Mismatch repair status, or DMMR, refers to the presence or absence, in the case of DMMR absence, of nuclear expression of the mismatch repair protein. So these two findings, these two manifestations, microsatellite instability and mismatch repair status, are highly correlated, but there are two different tests. So one is referring to the immunohistochemistry assay, and one is referring to a genetic assay. So a pathologist is absolutely needed for MSI. I think it's widely recognized that a pathologist is needed for mismatch repair immunohistochemistry, but it's also important to appreciate that a pathologist is needed for MSI, even though it is a molecular test. And the reason for this is critical for the pathologist to identify the tumor, and in the context of a MSI assay, we're using PCR to identify what's normal, so that there can be an appropriate identification of those areas, a macro dissection or micro dissection of those areas. A pathologist's role is critical to avoid tumor-infiltrated lymphocytes and large areas of necrosis, which will impair the functioning of the assay. So I also included these illustrative pictures for those who will have access to the slides. There's a green ribbon across the slide, and above it we have a control case, which is going to be completely normal, and below the green ribbon we'll have our index case. So an index case to show the results of capillary electrophoresis, which is what the PCR-based assay output appears as. And so above the green ribbon, this is in our match normal. You'll see for these pentas, which are the identity markers within the MSI assay, you'll see that the normal and the tumor show a match. And this is helpful because it gives us some confidence that the patient sample really has not been mixed up, because they're normal and the tumor match with this identity marker. And you can see for our index patient below the green ribbon that these two match as well, indicating that we have a match, and this is the patient. Now, if we look at one of the microsatellites, one of the mononucleotide repeat markers, above the green ribbon, you can see the normal and the tumor match, consistent with stability at this particular locus. And you can see in the tumor, the normal here, there is not a match. There are alleles of different sizes in the tumor compared to the normal, and this patient is unstable at this locus. If a patient is unstable at 2 or more loci using the Bethesda Consensus 5 markers, which many labs in the United States use, then this patient will be considered to be microsatellite unstable, or this particular result will be microsatellite unstable. And here's the red box showing you this unstable result. If you look at corresponding immunohistochemistry in the case of microsatellite instability, what you'll see, and I have the H&E here for the purposes of illustrating what the tumor looks like, you'll see that the nuclei of the lymphocytes are staining positively, and that highlights an intact internal control. This is really important to know that the tests work, and the same thing is true, of course, for MSH6. But you'll note that the tumor nuclei are negative or do not express the protein, and this is consistent with loss of MSH2 and MSH6. The presence of the internal control confirms that we have an informative result. There's a rare clinical situation in which patients will not have an intact internal control and it be a valid result, and that will be in the context of constitutional mismatch repair deficiency, which is really, really rare and is seen in circumstances where there's a consanguineous union of the patient's parents, where they may have biallelic loss of mismatch repair genes. So how should one screen patients for mismatch repair loss or microsatellite instability? And the older literature would indicate that 5 to 10% of cases where you have intact immunostains, you have microsatellite instability. You can see two references here from excellent groups in the field. And this led to routine combined testing, doing both mismatch repair immunohistochemistry and microsatellite instability testing. But I think more recent data you can see here from the Ohio State Comprehensive Collaborative Group, as well as this group in New York City, will show that discrepancy between microsatellite instability and mismatch repair immunohistochemistry is actually rare. I will say also in our practice experience at Mayo Clinic, this discrepancy is also rare, and I think many discrepancies that one encounters, as seen in this first reference here from gastroenterology in 2014, are likely due to interpretive challenges. So when discrepant cases are re-reviewed, they usually interpretive challenges in the immunohistochemistry that are resolved with re-review and allow us to appreciate that many cases are actually concordant, and the data will suggest that of the order of 99% of cases are actually concordant. So I think the data available to us currently today would indicate that universal screening by immunohistochemistry is satisfactory, but I think it's important to emphasize that it requires knowledge and experience in the interpretive challenges. There are many cases that are straightforward, but there are some cases that are not. Immunohistochemistry is advantageous for most pathology workflows because it's readily available and widely accessible across the country. There's a very rapid turnaround time of same day or next day in many settings, and you can identify the gene that is involved, which will have relevance to downstream molecular testing, and immunohistochemistry is relatively inexpensive. There are some tips that I've included on this slide for the interpretation of immunohistochemistry. I think it's really important to identify appropriate controls to maintain the assay in your lab. It's relevant and very critical that you pay attention to the presence of the internal control in your assay when you're reviewing your stains. If you identify a confluent area of loss of staining with a retained internal control, that's very likely to be a true loss of staining. There are unusual patterns, but they're actually uncommon. And there is actually a paper discussing discordant immunohistochemistry results on microsatellite instability results from Wendy Frankel's group that will be a useful reference for people to review. It's from 2018 in Modern Pathology. But if you sum up their data, and again, if you look at the data from references in the prior slides, unusual patterns really are uncommon. So if you're doing a large volume of testing, you'll see unusual patterns of the order of 10% of the time, but they're quite uncommon. And if you encounter a pattern or a result that you feel uncertain about, it's certainly reasonable to ask for help, to send it to a pathology group where you can get an expert opinion. Now, MSI by NGS is a relatively new platform, and the available data from 2017 and subsequent to this will indicate a high degree of concordance between next-generation sequencing and MSI by PCR and MMR IHC. Now, MSI by NGS may have some advantages, and I'll kind of have a summary table shortly in the presentation to highlight the advantages and disadvantages of the various methods. But for now, MSI by NGS may have a slightly higher sensitivity because it examines many more microsatellites. It does not require normal, which makes it a logistically easier test to deploy because you don't have to track a normal. You can just use a tumor sample or identify a normal. And I think in this excellent study by Heather Hampel's group published in JAMA Oncology in 2018, there are a number of very useful messages. Two of the key messages I've included on this slide. The first is that tumor sequencing up front by next-generation sequencing may be simpler and more efficient in the long run. If you were to perform MSI testing by NGS, you can also assay for multiple other markers, determine those patients who are likely to have Lynch syndrome, those who are unlikely, or highly unlikely to have Lynch syndrome, and also identify a number of other critical biomarkers. And I think another key message from that paper is that these platforms, NGS, PCR, and immunohistochemistry, are highly concordant. So each of these platforms are valuable and useful and valid ways to screen patients with Lynch syndrome. Now here's the table that I mentioned previously where you examine the various methods of testing for microsatellite instability, the advantages and the disadvantages of each. Right here I have an asterisk below highlighted that there are other methods that exist. So this table doesn't include all the methods, but certainly this is the majority of the methods that are actually used in the U.S. widely in clinical practice. As I mentioned, the advantage of immunohistochemistry is inexpensive, widely available, and with a rapid turnaround time. It's excellent for very small samples. Of course, PCR and NGS can work well for small samples as well. One of the benefits of MSI by PCR is that it's very easy to interpret, as I showed you previously, and it really is well optimized for colorectal cancer. One of the downsides of the PCR-based assays, it requires match normal, and it takes about 5 days in many practices to be turned around. Immunohistochemistry has some challenges. I think it's important to be aware of the interpretive challenges, especially in the context of post-neoadjuvant therapy. MSI by NGS has a number of advantages. It can be multiplexed with other biomarkers. It has a high sensitivity across multiple tumor types, but it may take a long time to go through the workflow of doing an NGS-based MSI screen, and it does require complex informatics, much more complex than would be needed for the other methods that are listed here. So beyond Lynch syndrome diagnosis, the detection of microsatellite instability has other important clinical applications that are used in the real world routinely today. And those are first to provide prognostic information to patients, which is really important, and also to provide predictive information, which is incredibly important in today's practice. So if you handle prognosis first, tumors that are microsatellite unstable or characterized by deficient mismatch repair protein expression have a better prognosis than their microsatellite stable counterparts. And indeed, the microsatellite stable BRAF mutant colorectal cancers have the worst prognosis if you were to stratify cases based on their microsatellite status and their RAS gene or BRAF status. The MSS BRAF mutant are the cases with the worst prognosis. Of critical importance, and from these seminal papers published in New England Journal of Science based on landmark clinical trials, patients with microsatellite instability or deficient mismatch repair protein expression are much more likely to respond to PD-1 inhibition, and this led to FDA approval of these assays detecting microsatellite instability or deficient mismatch repair protein expression to predict patients who would respond to PD-1 inhibition. And this is a major practice change, and consequently the volume of microsatellite instability tested across the country has increased and represents opportunity for patients to have access to these therapies, which can have a major impact in the response and their treatment outcome. So actually in my clinical practice, I include the MSR, MMR status in my reports. If that information is available, I include it either in a synoptic, in the context of a synoptic report. Sometimes I issue it in an addendum or in a comment. It depends on when this information becomes available to me in the context of the case. But I include this information because it has powerful utility for the patient's care and is really critical in the diagnosis and management of colon cancer. So I'm going to make a brief segue to address germline molecular testing, and I think it's useful if you're going to be evaluating patients with colon cancer, which is many practitioners across the country, to have some understanding beyond Lynch syndrome of other indications or reasons to consider germline molecular testing and what testing one would consider. So this additional molecular testing may be helpful in the assessment for other syndromes. They're going to be less common than Lynch syndrome, which is the most common, but there are things that you're going to encounter in clinical practice. And when do I think of syndromes? If I encounter a clinical case where there are multiple or many gastrointestinal polyps, in patients with multiple malignancies, I think of syndromes. And if I identify a syndrome-associated lesion, for example, a Put-Seeger's polyp on an endoscopic GI biopsy, then I think of the possibility of a syndrome, and I may note this in my report or have a conversation with the ordering provider to make them aware of this possibility to trigger the appropriate follow-up and testing. And so some other hereditary colorectal cancer syndromes to consider are familial adenomatous polyposis. There's classic and attenuated variants. There are two syndromes that can mimic, in quotes, FAP, MYH-associated polyposis, and NTHL1 germline mutations. There's also Put-Seeger syndrome, juvenile polyposis syndrome, and P10 hamartoma syndrome. And I will say that in our experience here, we are in a large academic practice and a referral center, but I've seen examples of all of these in our clinical practice, some of them previously recognized, some of them as first-time diagnoses. And so in practice, these are syndromes that you will encounter and have the potential to impact not only that individual patient, but their families. And so it's useful to be cognizant of these possibilities and to raise them where they're indicated by the clinical features. And so now we'll return to the somatic testing for the rest of the talk. So now we've talked quite a bit about microsatellite instability, and I think that's prudent because of its trifold usefulness: diagnosis of Lynch syndrome, prediction of response to PD-1 inhibition and immunotherapy response, and also prognostication. But there are also KRAS, NRAS, and BRAF, which are critical biomarkers, and clinical tests to detect these mutations are a critical part of care. I included this link in response to a question submitted in advance showing the drugs that have been approved by the FDA for treatment of patients in the context of colorectal cancer, and they include drugs that are where the results of these tests are actually informative to the treating providers. So what these assays will do is inform the adjuvant treatment choice, and this is actually noted in the FDA approval of these treatments, and to improve the efficacy by only prescribing anti-EGFR inhibitors to patients who lack mutations in these genes. But importantly, from this critical reference here in New England Journal in 2013, patients who have KRAS and RAS mutations, if they receive anti-EGFR therapy, there's a greater likelihood of these patients dying of disease. And so by performing tests that identify mutations in these genes, we can prevent patient harm. It's important to point out, too, at this point, that we don't only want assays that examine exons 2 of these genes, but also we want to examine exons 2 through 4, because this extended RAS testing or comprehensive RAS testing will ensure that you cover not just only codons 12 and 13, but additional codons where they're activating mutations, which actually will allow the providers to make an appropriate choice that is not to prescribe the anti-EGFR or anti-EGFR therapies in patients who harbor mutations outside of these codons to, again, improve efficacy and prevent patient harm. So there was also a question submitted concerning what FDA cleared or approved assays are there for colorectal cancer care, and I've listed them here on the left side of the screen. These 5 assays are approved or cleared by the FDA for that particular indication. I think it's also incumbent on me to mention that there is strong literature showing that there's a high quality performance of lab-developed tests. And they actually have equivalent performance to FDA-approved assays. And there's some literature that's published here, including this excellent paper in JAMA Oncology from the CAP Molecular Oncology Committee, who reviews proficiency testing for labs across the country and international labs, showing that the performance is equivalent. And also this reference also from this group examining the performance on proficiency testing across the country, looking at various platforms. So lab-developed tests, though not FDA cleared or approved, actually have equivalent performance. And I think the critical keys are to know your lab. I think if you are having testing in a lab, you really want to know your lab. And it's important to ask about the validation of the quality data from the lab as they present the offers that are available. I think it would be useful to read these references and examine them, because I think they have critical information that I think will be informative to both ordering physicians and to pathologists. And I've included the link here to the FDA-approved companion assay. I think important tips for pathologists who are going to be participating in the molecular testing workflow. I think it's important that pathologists understand their role to select an appropriate block for ancillary molecular study. While molecular tests are incredibly powerful, they require excellent pre-analytic phase, where pathologists will identify material that will include appropriate amounts of tumor and avoid, where possible, too much normal. You don't want to dilute the tumor DNA too much. And I think most clinical assays have a limited detection of 5%. Not all. It depends on the analyte and what's being examined. But I think it's prudent to know what the limited detection is in the assay. And the key variable on the slide is the percentage of tumor nuclei, not the area of the tumor, but how many nuclei are from the tumor itself. And so pathologists actually play a vital role in ensuring the judicious use of tissue, and this is a role not to be underestimated. I would also say that if you are sending your material to a laboratory, it will be important to inquire whether pathologists are involved in this pre-analytic step. So the question has arisen before, what about doing comprehensive profiling on all cases? In many settings, this is cost prohibitive because the comprehensive molecular profiling, looking at hundreds of genes on each case of newly diagnosed colon cancer, is not affordable in many settings. There is a definite benefit of universal Lynch syndrome screening, but I think additional molecular testing is indicated most readily and most strongly in those patients where adjuvant treatment is an option. And there's undoubtedly selected situations in which comprehensive profiling is helpful. And so in these situations, you may identify some other targetable alterations which I've not covered in detail, like ALK fusions and NTRAP fusions, but these are uncommon across the body of colorectal cancers, of the order of 1% or less. And I mentioned here that there is a TRAC immunostain that can be used as a screen, and I think data are still emerging on the usefulness of this antibody, although preliminary data will suggest that it is encouraging. I've included this table to illustrate some indications for various assays, and you can see the information here. Mismatch repair or microsatellite instability testing is used to predict response to PD-1 inhibition, identify patients with Lynch syndrome, And we use this universally in our practice and in many practices at diagnosis. Tumor mutation burden has been suggested to be useful to predict response to PD-1 inhibition in the context of stage 4 colon cancer. And while the retrospective data from studies has been very encouraging, I'm not aware to date of an encouraging prospective clinical trial, and so I don't think that the jury is completely in on the usefulness of tumor mutation burden to predict response to PD-1 inhibition separate from the above microsatellite instability testing. But there's certainly more to come on this, I'm certain. We've mentioned the RAS and RAF genes before and their usefulness in predicting response to anti-EGFR therapy, and of course there is some prognostic information available from testing in this regard. This is most useful in patients with stage 3 and stage 4 colon cancer, but there are some settings in which this information is used universally, and certainly I've mentioned this before, again, in the context of BRAF, in those laboratories who do a cascade, beginning with mismatch repair immunohistochemistry, adding BRAF in the context of patients who have MNH1 and PMS2 loss. Identification of NTRK fusion predicts response to NTRK inhibition, which is shown to be a very key biomarker, but in many instances I think that this is used in stage 4 colon cancer most effectively, though a rare alteration, used most effectively in this context. And so to summarize, universal Lynch syndrome screening I think is definitely recommended, and the value of that is established. I think mismatch repair immunohistochemistry, MSI, and NGS, MSI by PCR and NGS are practically equivalent based on the available data, and I think many others in the field will believe this to be the case. Deficient mismatch repair or microsatellite instability predicts response to PD-1 axis inhibition, and so it's clinically very important. I think it's useful to consider other hereditary GI tumor syndromes if there's some clinical concern based on the ordering providers' provided information or based on what you see pathologically on the material submitted. And KRAS, NRAS, and BRAF status are both prognostic and predictive value in the context of colorectal cancer care. So I've shared what, how, and when we order molecular tests in our practice, and certainly what I've seen in practices that I interact with. I think a critical component of all of this is that you need to have a thoughtful diagnosis, a thoughtful dialogue between your clinical colleagues if you're a laboratorian, or with your laboratorian if you are a clinician, to determine what, how, and when molecular tests will be performed. And so now time is available for questions. I've changed to the slide with the information on how to submit a question. Thank you.
Thank you, Dr. Graham. At this time, we would like to take any questions that you have. Okay, well, thank you for participating in today's specialty testing webinar. If you have additional questions, please indicate them on the evaluation that will be forwarded to you shortly. Please note, laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us today.